Good evening to you all. First and foremost, I thank the organizers for giving me this opportunity. In the next few minutes, I will be just reviewing the evidence on the use of procalcitonin. And I will be concentrating on trials from 2010 to 2022, the last 12 years. This is a quote by a famous physiologist. It makes no sense to use 21st century technology to develop drugs targeted at specific infections whose diagnosis is delayed by 19th century methods. That means the diagnostic armamentarium is very at the infancy. And to be honest, there is no biomarker which is safe and reliable to predict sepsis. And this many times causes delay in the initiation of appropriate antibiotics. An ideal biomarker should help in identification or rule out occult disease, should be highly sensitive and specific with biologic plausibility, should be easily measured and with a rapid turnaround time, and should have a prognostic value and affordable. None of the biomarkers meets all these criteria. And Procalstonin was invented in 1993 as a biomarker indicating bacterial infection. In the physiological state, it is produced by the C cells of thyroid gland. But when there is a systemic inflammatory response syndrome, it is produced from liver, lung, pancreas, and other tissues, and this is detected in the blood. In the normal physiological state, only a very negligible amount is seen. So let us review the evidence on the initiation of antibiotics. A major study published in the Lancet Infectious Disease in 2013, which reviewed 30 observational ICU and non-ICU studies. And they found out a sensitivity of 77% and a specificity of 79%, and concluded that PCT is a potential marker when interpreted in the clinical context. So that's very good. Then these are review of various observational studies which all tells that procalcitonin is a good predictor of bacterial infection, but the cutoff or the threshold value varied. Two large studies done in the emergency department also concluded that PCT is a useful marker in excluding bacteremia. And another study by Sharma and group, PCT and change in PCT predicts bacterial infection and anastomotic leak in surgical population. So then came the surviving sepsis guideline of 2021, which says that procalcitonin is not that good. Although it's a weak recommendation, their review found out a very poor evidence for the use of procalcitonin in initiating antibiotic. Their conclusion is based on the meta-analysis of 3 randomized controlled trials, very good quality studies, and they could not find any mortality benefit or any advantage in the length of stay in ICU or hospital. Because of the lack of any apparent benefit with procalcitonin, limited availability of procalcitonin, unavailability of cost, the surviving sepsis guidelines did not recommend using procalcitonin in initiation of antibiotics. But here we have to mind that the evidence for this was very low. Now let us take the community acquired pneumonia. The 2021 guideline states that empiric antibiotics should be initiated in clinically suspected and radiologically proved community acquired pneumonia regardless of the initial procalcitonin level. It's a strong recommendation with moderate quality of evidence. The reported sensitivity of procalcitonin ranges from 38% to 91%. That is, in up to around 61% times you can go wrong if you depend on procalcitonin to initiate antibiotics in community acquired pneumonia. So to conclude, there is no significance of procalcitonin to initiate antibiotic for community acquired pneumonia, but it may be useful in guiding or early discontinuation of antibiotics in CAP. Coming to the ventilator-associated pneumonia, the IDSA guidelines in 2016 says that for patients with suspected VAP, we recommend using clinical criteria alone rather than using procalcitonin plus clinical criteria to decide whether or not to initiate antibiotic therapy. And they also concludes that procalcitonin level plus clinical criteria may be used to guide the discontinuation of antibiotic therapy. That is, to stop antibiotics, procalcitonin has a role. But to initiate procalcitonin, there is no clear-cut evidence. So the summary of evidence in pneumonia is that procalcitonin plus clinical criteria can diagnose the healthcare-associated pneumonia with sensitivity of and specificity of 67 and 83% respectively. That is, if we use procalcitonin according to these studies, we can go wrong up to 33 plus 17% of times. That's almost 50%. In a Cochrane review of 14 trials with 4,000 plus patients, they found that the PCT-based decision making reduced the antibiotic duration. So there is a role for stopping antibiotics based on procalcitonin. Now, looking at the procalcitonin levels for ruling out bacterial co-infection in ICU patients with influenza, the chi-square automatic interaction decision tree analysis showed that it has a good sensitivity and a good negative predictive value. So that means if you have a patient with influenza in your ICU and you are suspecting a bacterial co-infection, look at the PCT. If PCT is less than 0.25, it has a good negative predictive value. You need not initiate on antibiotic. Now, it's another clinical condition, like you get a patient with respiratory distress and you are in doubt whether to start antibiotic or not. In such cases, procalcitonin may aid in the diagnosis of pneumonia, particularly in cases with high diagnosis uncertainty. According to the BAC trial, PCT may aid in the decision to administer antibiotic therapy to patients presenting with acute heart failure when clinical uncertainty exists regarding a superimposed bacterial infection. So this is regarding the evidence on the initiation of antibiotic depending on procalcitonin value. So there is no clear-cut evidence for that, but we need to have more RCTs to conclusively recommend procalcitonin on initiation of antibiotic. Coming to the evidence of procalcitonin as a prognostic marker, the Moses trial state that the procalcitonin decrease of greater than 80% from baseline on day 4 and 28-day mortality. They compared that. More than 800 patients were enrolled, and the 28-day all-cause mortality was almost 2 times higher if PCT did not decrease on day 4. There is 20% mortality compared to 10%. So they concluded that procalcitonin is an independent predictor of mortality. Then the triage study, which is a multi-center prospective observational study of more than 6,000 patients, a very large study. Mortality increased stepwise with higher PCT values. PCT was a strong and independent outcome predictor of 30-day mortality across different medical diagnoses, independent of underlying infection. And these are a few large observational studies which compared the prognostic value of procalcitonin in predicting the mortality. To conclude, elevated procalcitonin and non-clearance of procalcitonin was associated with increased mortality in septic patients. And coming to the evidence of Procalstone-based therapy on antibiotic duration, whether we can stop antibiotic depending on the procalcitonin value. A large meta-analysis of more than 3,000 patients. And the trials had a cutoff of 0.5 nanogram per ml and the decrease in PCT by 80 to 90%. And the review concluded that PCT guidance reduced antibiotic duration by 1.49 days with no adverse impact on mortality or ICU length of stay. And these are few large RCTs which compared the procalcitonin-based or procalcitonin-guided therapy versus the standard treatment. When procalcitonin-guided therapy was used, there was a reduction in the number of days antibiotics were used without much effect or adverse effect on the mortality. The PROACT trial, which came out in 2018, which was done in the emergency department, which was a review of, which is a multi-center study of 14 EDs. The overall adverse events were similar in between the two groups, and this trial did not show any difference in the mean antibiotic duration. Then came the pro rata trial, which showed a decreased in the antibiotic days with procalcitonin, but a mild or non-significant increase in mortality in the procalcitonin arm. Then came the SAPS trial, which is the stop antibiotic on procalcitonin guidance study, which is a high quality study and published in Lancet Infectious Disease in 2016. And Procalstone-based therapy decreased duration of antibiotics. That is, the mean antibiotics was 5 days and the control group was 7 days. And the 28-day mortality was 20% in the procalcitonin group compared to 25 in the control group. And 1 year mortality was 36 in the procalcitonin group with the 43% in the control group. The SAPS trial says that the length of or the duration of antibiotic administration is less in the procalcitonin group, and also the mortality is also less in the procalcitonin group. So why the mortality is less in the procalcitonin group? Is it because of the adverse effects resulting from the antibiotic use? That we will come to later. So these are some of the good quality studies where procalcitonin was used for antibiotic discontinuance. So overall, most of the trials show a moderate reduction in antibiotic duration. PCT cutoff varied widely between the trials, and one trial showed an increase in mortality, which we have already discussed, and patients were predominantly medical, and PCT guidance decreased antibiotic exposure without adverse effect in the patients with lower respiratory tract infection. So procalcitonin to reduce long-term infection associated adverse event in sepsis. This is why the procalcitonin-based therapy probably is reducing the mortality. This study was a multicenter trial of 266 patients in a heterogeneous patient group. The cutoff of PCT was less than 0.5 nanogram per liter and 80% reduction on day 5. The rate of infection associated adverse event was 77.2% in the PCT group compared to 15.3 in the control group, and the 28-day mortality was 15.2 in the PCT group and 28.2 in the control group, and the mean antibiotic duration was 5 days compared to the 10 days. And this one trial which was published in 2021. So to conclude, in stopping antibiotics, procalcitonin has a role. Evidence supports that. Coming to burns, there is not much robust evidence of use of procalcitonin in burns. Daily measurement may be useful in monitoring effectiveness of antibiotic therapy, but a threshold value has not been described. Coming to the acute pancreatitis, the World Society of Emergency Surgery's Guidelines 2019 states that procalcitonin is the most sensitive lab test for detection of pancreatic infection, and low serum values carries a strong negative predictive value, even though it's a weak recommendation because of low quality of evidence. A recent study, the predictors of severe and critical acute pancreatitis, a systematic review, says that a procalcitonin value of less than 3.8 nanogram per ml or higher within 96 hours has got a good sensitivity in predicting pancreatic infection. So more robust studies are required for the significance of procalcitonin in pancreatitis. To conclude, no robust evidence to initiate antibiotic in sepsis, community acute pneumonia, healthcare associated pneumonia, burns based on procalcitonin values. It can be used to de-escalate antibiotics or reduce the duration of antibiotic use. Higher values are associated with poor outcome. For patients who have a PCT of less than 0.25 persistently and alternate diagnosis are made, antibiotic can be discontinued. That is, PCT has got a good negative predictive value. PCT, in addition to clinical criteria, can be used in VAP to discontinue antibiotics. So, to conclude, more randomized controlled trials are required to have robust evidence on the use of procalcitonin. Thank you.